Thanks so much, Diego. I do have financial disclosure. I'm on the advisory board for Horizon Pharma, which does make teprotumumab, which we'll talk about a little bit later. I think one thing that we always have to remember is that we have a lot of people that can help us with this disorder. So don't be, afraid to ask some of your colleagues for help when you need them. Primary care doctor, internal medicine with endocrinology, rheumatology, et cetera, et cetera, et cetera. So keep that in mind when you take care of these patients because they can often help bail you out. So what's the first thing we have to do? We need to get the thyroid under control. That's the first thing I ask these patients when they come in is whether their thyroid is under control because we do know that the course of thyroid eye disease is affected by the level of thyroid dysfunction. And in addition, some of the other systemic problems such as diabetes are more common in this disorder. The question more than anything else is whether you should use medicine, radioactive iodine, or thyroidectomy in taking care of the thyroid, and that's something that you should have an active discussion with the endocrinologist. Medical treatments, methylizmazole, PTU, they inhibit thyroid peroxidase and block thyroid hormone synthesis. And then we have radioactive iodine. However, there is evidence that radioactive iodine provokes or worsens orbitopathy. I sort of think of it as just setting off a bomb in the thyroid in the sense that it just liberates antigen. And I think it's be wise to treat some of these patients perioperatively with our peri-ablation with prednisone. And I do that for any of my high-risk patients or any who are active. And it's also very important to treat the hypothyroidism immediately. You don't want to let these patients get hypothyroid after the ablation. That's not something that you'd necessarily treat, but it's something that you should discuss with the endocrinologist to make sure that they don't go hypothyroid after ablation. The question is well, how does radioactive iodine do versus antithyroid drugs? There is evidence that radioactive iodine can get the thyroid under better control. However, it does increase the risk of ophthalmopathy compared to medications. So lately, there's been a push for thyroidectomy in these patients. So the idea more than anything else is that rather than setting off a bomb in the thyroid, you're removing that without liberating antigen. And this may result in attenuation of the immune reaction against the orbital antigens. And, sometimes people will follow it up with radioactive iodine if they didn't get the entire thyroid. There have been a couple recent studies that do show that thyroidectomy is more effective with regards to controlling the orbitopathy compared to radioactive iodine. And there was a recent study, relatively big data with almost 8,500 patients, 9% of which developed ophthalmopathy. However, surgical thyroidectomy alone or in combination with medical therapy was associated with a 74% decrease hazard for ophthalmopathy compared to radioactive iodine alone. So I think that's something that I'm seeing more, at least in the US, is sort of a push for thyroidectomy, especially in some of the high-risk patients. So what should you do? Well, first get your thyroid levels under control with the help of the primary care doctor or the endocrinologist. If there's significant worsening of the disease, then I might consider thyroidectomy. And if there is evidence of orbitopathy or high-risk patients for progression, if they're going to undergo radioactive iodine, I would treat those patients with prednisone around the time. And again, don't let these patients go hypothyroid because there is evidence that that makes it worse. It's important to tell these patients to stop smoking. I have colleagues who sort of refuse to treat their patients if they don't stop smoking. So it's something that you always have to hammer into them. So now we really just have to control the inflammation. So how are we going to control it? We have steroids, that could be IV versus oral, radiation, antimetabolites, or the newer biologics. So again, in order to treat the inflammation, we ought to at least be able to grade it. I like the clinical activity score. I think it's pretty reproducible and it's helpful. I know that when I see these patients afterwards, I have an idea of whether their inflammation is worse or better. And then I sort of think of these patients with regards to whether they have mild, moderate to severe, or sight-threatening disease. Obviously, sight-threatening disease is going to be those patients with optic neuropathy or corneal breakdown. And then the difference between mild and moderate to severe is really whether it impacts their daily life a lot. So in mild disease, you're not going to have much of an impact, but in moderate to severe, you're going to have enough of an impact that you might that you're going to consider treatment in order to decrease the inflammation. Selenium is something that I do have patients take. I think, the jury's still out with regards to how well this works. The original article in the New England Journal of Medicine was criticized because some of the patients came from a selenium deficient part of the world. But I think most of us would supplement. I think it's a benign medication. I think the risk is low, although they do say that there's a risk of type 2 diabetes and peripheral vascular disease. I give them in the paper, basically dictated giving them 100 micrograms twice a day for 6 months. So I almost do this on all my patients who are active that when I first see them. It gives them something to do, I think, which is nice as well. With regards to corticosteroids, I think studies have shown consistently that IV glucocorticoids are superior to oral. And so I don't use oral steroids in my thyroid patients, except if I'm going to bridge them to a decompression or if they're going to get radioactive iodine. So then I might give it to them perioblation. But, basically, there's a significant advantage in terms of efficacy of IV glucocorticoids versus oral. And there are some risks to it, but I think they're relatively low. There's a risk of acute liver disease, and so I think it would be wise to check the liver enzymes prior to starting it, and maybe again during the course of the steroids. So this is why I hate oral steroids. So here's a patient. She was seen relatively early in disease. One of my colleagues who likes oral steroids put her on 6 months of steroids, and there she is. And she's, I was not happy, and she was not happy. So what is the typical dose for these moderate to severe patients? This is the UGO-GO protocol. So it's going to be 0.5 grams every week for 6 weeks. So 500 milligrams of Solu-Medrol per week for 6 weeks, followed by 250 milligrams of Solu-Medrol per week for 6 weeks. And the thought is that if you keep these patients under a 6-gram cumulative dose, it's relatively safe. So with the typical dose, you're going to just get to 4.5 grams. And basically, the question is whether you need to do anything for these patients when you give it. In general, we don't think that routine precautions are necessary, or at least there is some evidence that it's not. With regards to severe disease, though, those patients with optic neuropathy, you're probably going to treat them a little more stringently. So you're going to go to a high dose of Solu-Medrol. Other immunosuppressive agents, cyclosporin, azathioprine, methotrexate, diclofenac. I mean, I personally don't think that these are ever going to be embraced. I do have colleagues who like them and use them, but I think it's something that's probably not going to be used in the future. Usually they're compared to or in combination with oral steroids. So the other thing that we consider is radiation. It's nice because it delivers a local therapy to the area. I think that I use radiation in those patients that are active who have a lot of motility disturbance, and I think that's really the best people to use them on. So disadvantage, though, of radiation, obviously can't do it in pregnancy. You can't do it with patients with diabetes due to the risk of radiation retinopathy. So keep that in mind for these patients. And then some people add corticosteroids as well as radiation, which I think is reasonable. So I have a very little time to talk about biologics. I'm at the end of my time. So I'm just going to talk about rituximab quickly, followed by a few others. Rituximab, basically contradictory results out there, a lot of excitement early on, and then there's 2 recent studies that basically tell us 2 different things. And so jury's still out, but I think there's probably a role in corticosteroid-resistant patients. Adalimumab, small studies, not a lot of evidence. More promising, though, are teprotumumab and tocilizumab. Teprotumumab has been shown to have, this is the new drug that was just FDA approved in the United States just this week. And so lots of promise with regards to it. I think it's going to be interesting to see how it goes. This is insulin growth factor receptor antibody. Tocilizumab, I've heard that also has a lot of good results, not approved, at least in the US, for thyroid eye disease, but again, a lot of success described with regards to using these patients, especially in those that are corticosteroid resistant. So I think there's a lot of excitement going on with regards to thyroid eye disease. I think there's some basic things that we need to take care of early on in these patients. We're entering a new era with regards to taking care of these patients with the biologics that are available, and it'll be interesting to see how this all goes. Thanks.